Welcome, everyone. Thank you all for coming. My name is Yushen Qian. I'm a radiation oncologist here at Stanford. And in talking about prostate cancer, I would like to talk to you today a little bit more about diagnosis, PSA screening, and more something you heard just now, active surveillance, and a little bit of what it is. So, just sort of taking a step back, prostate cancer, what is it? It's the most common cancer that affects males in the United States. In fact, there's a 1 in 7 lifetime risk in the United States. In 2022, there's expected to be about 270,000 cases with 34,000 deaths in the US due to prostate cancer. Prostate cancer accounts for about 14% of all cancer cases in the US and 6% of all cancer deaths in the US. And as you can see, the survival after diagnosis of prostate cancer has significantly improved over time. In terms of the demographics of prostate cancer, big factor is age. It's extremely rare to have an aggressive prostate cancer at a very young age. Race plays a role with increased prevalence in African American populations, followed by Caucasian populations, followed by all others, as you can see in the graph. There's also genetic predispositions. The BRCA gene is a known risk factor, as well as family history. So let's talk a little bit about the natural history. What happens with prostate cancer? Without screening, many cases of prostate cancer do not ever become what we call clinically evident. So what does that mean? That means that these cancers often grow so slowly that most men will die of other causes, as Dr. Sun alluded to, commonly heart disease. And specifically, what this means is that most men who choose not to be screened, and that's with a PSA test we'll get to, will not be diagnosed with prostate cancer and will die from some other cause. And although some of these unscreened men will eventually die from prostate cancer, overall, the risk is very low, specifically less than 3%. In terms of survival from a diagnosis of prostate cancer, that's mostly due and determined based upon the extent of disease, whether that disease is localized to the prostate, and there are variations of localized, or metastatic, meaning that it has spread to other parts of the body. The most common presentation is an abnormal PSA on screening, meaning no symptoms, just an elevated PSA. And these are cases where we will call them screen-detected cases. So we've talked a lot about this PSA. You hear it all over the literature. So what is PSA? So the PSA stands for a prostate-specific antigen. A prostate-specific antigen is a protein that is produced by both, importantly, cancerous and non-cancerous tissue in the prostate. And the PSA test is a blood draw that you get drawn in your lab, and it measures the amount of this protein, this PSA, in your blood. Importantly, looking at this graph, there are several reasons why your PSA can be elevated. There's prostate cancer, which is what we're talking about, but other reasons, and then having a normal enlarged prostate, having a bacterial infection of the prostate, recent ejaculation or sexual activity, having had instrumentation or digital rectal exam, having had a physical exam just prior, as well as something benign and something I never even knew before I got into this, bicycle riding, or sometimes here, horseback riding. So what we encourage is a shared decision-making process. So what does this mean? A shared decision-making process means that you, as the patient, and your clinician should engage in making a decision together in regards to discussing screening, meaning that you should consider both the benefits and the harms of screening. Again, the screening is done with the PSA test only. And again, I want to make the emphasis that this is not a specific test for cancer, and that other factors that we had just talked about can elevate the PSA. And screening will often lead to a prostate biopsy, which Dr. Sun had alluded to. And so overall, I want to make this point very clear, is that there are no available tests that we have right now that can tell us and determine with accuracy which men who are diagnosed with a prostate cancer on screening will have a cancer that is destined to cause health problems and would most likely benefit from aggressive treatment, and which one of those prostate cancers are more quote unquote indolent and really wouldn't be the thing that takes us. So getting a little bit into the nuances of screening. So let's talk a little bit more about the benefits versus harms. So screening overall undoubtedly increases the detection rate of prostate cancer. And there have been evidence from multiple, randomized controlled trials that has shown that screening does have at most a small benefit in reducing prostate cancer mortality. And that means mortality and death due to prostate cancer. But in order to prevent one death from prostate cancer, we need to put 570 men through screening. So that's a lot of men that are needed to undergo a procedure, screening, in order to prevent one death. So what are the harms of screening? Well, screening can lead to prostate cancer biopsy, and biopsy can have risks such as infection, pain, bleeding, urinary symptoms. Although these rates are rare and rarer at Stanford, there could be overdiagnosis of prostate cancer, meaning would the prostate cancer have become clinically significant in this patient's lifetime? Would these be more indolent, or they would? Is this a cancer that would be more indolent, or would it cause more problems? There could be associated treatment-related side effects of the treatment, whether surgery, whether radiation, surgery side effects, and HIFU side effects, such as what you've heard from Dr. Sun. PSA could be falsely elevated due to several factors. Anxiety, knowing that we have an elevated PSA can also cause anxiety. So there's several harms and several factors to be taken into account when we think about screening. So in practice, there are several national organizations: the American Urological Association, U.S. Preventative Task Force, National Cancer Consortium Network, and there's some variability about the age to begin screening for most men with prostate cancer. But in practice, I think a good rule of thumb to think about is that for most men who we expect with life expectancy greater than 10 years, 50 years of age is a good time to initiate screening. Certainly, there are some limited evidence that suggests that for higher risk populations, it's very reasonable to initiate screening at an earlier age point, age 40 to 45 years, in patients with higher risk factors that we had talked about: genetic predisposition, BRCA carriers, Lynch syndrome, African Americans, and patients who have a family history of prostate cancer, especially in first-degree relatives who are diagnosed at an early age. In screening, testing is done every 1 to 2 years, and we generally offer screening up to 70 years of age. So let's say you undergo a PSA test, you're starting to undergo screening. What is an abnormal PSA? The answer is it depends, but a good number to think about is 4. So for a PSA greater than 4, the positive predictive value, meaning that if you have a PSA greater than 4, there's a 30% chance that there's actually cancer. For a PSA of under 4, there's actually an 85 negative predictive value, 85% chance that there is no cancer. And it's important to keep in mind that a normal PSA varies with age. For a patient in their 40s, the upper limit of PSA is actually 2.5, whereas as we go up in time, or up in age, up to 79, the upper limit of PSA can be up to 7. So going back to how, the diagnosis of prostate cancer, again, the most common presentation is an elevated PSA. There are instances where larger tumors can sometimes cause what we call obstructive urinary symptoms: increased urgency, increased frequency of urination, urinary obstruction, blood in the urine, stool, ejaculate. Metastatic disease that goes elsewhere in the body, can sometimes present as back or bone pain. And what will happen when you go see your doctor with to talk about prostate cancer? They'll want to do a comprehensive history and physical, and they'll often ask you things related to your sexual and urinary function. They'll want to know about other medical conditions that you have, specifically with interest in terms of heart, lung, GI diseases. They'll ask. They'll be also interested in what other prostate procedures that you have. If you've had any procedures to decrease the bulk of prostate due to a bulky prostate that's causing urinary symptoms. If you've taken some other medications, one of which is known as 5-alpha reductase inhibitors, that could potentially affect the PSA value. They'll often do a digital rectal exam in order to feel how the prostate feels. And we'll be interested in your PSAs, both now and any prior PSAs you have, and as well as other blood work, including a complete blood count, comprehensive metabolic panel. So the biopsy, and then we'll get a biopsy, which Dr. Sun had alluded to, which can most often be transrectal ultrasound guided and or combined with the MRI fusion. And just another schematic of a biopsy, the prostate is divided into 3 levels from the base, middle prostate apex, 2 on each side. So at least 12 samples are taken. And under an ultrasound, you can see that most prostate cancers are darker, or what we call hypoechoic. So how do we think about prostate cancer? Prostate cancer is a little bit different than most other cancers we read about on the internet. Most other cancers you've heard of, we'll talk about them in terms of stages, 1 through 4. Prostate cancers, functionally, we think about them in terms of what are called risk groups. There's a low risk group, a middle risk group, and a high risk group, and some sub-classifications within them. But the big point I want to make here is that the risk group is determined upon 3 main things. One is the T stage, which is determined based upon the digital rectal exam, or the MRI, the PSA level, and the Gleason score, which we had there were some questions about earlier, and we'll get to. And let's talk about the T stage. The T stage is basically how advanced the prostate cancer feels on a digital rectal exam or on an MRI. This is an example of a tumor that is coming out of the capsule of the prostate, so with extracapsular extension. In a more advanced case, this is a tumor that invades into the seminal vesicles, and so this would be a T3B tumor. And the Gleason score. So the Gleason score is the score that the pathologist will assign your prostate cancer specimen when they look at it underneath the microscope. It is a reflection of how atypical the cells look. The number ranges from 1 to 5. In prostate cancer, we're generally talking about 3 to 5. And a Gleason pattern 3 cancer, as you can see in the picture, has still maintained glandular tissue, similar to what normal prostate cells look like. Whereas a Gleason pattern 5, which is the most advanced form, there's just sheets of cells with loss of glandular architecture. So we hear about the Gleason score, 4 plus 3, 3 plus 4, 3 plus 3. Why are there 2 numbers? And the Gleason score represents the sum of the top 2 Gleason patterns in order of prevalence. So Gleason 4 plus 3 tumor means that the most prevalent pattern is a Gleason 4 cancer. And then the second most common pattern is a Gleason 3 tumor. There's also something you may hear about in the literature, such as grade group. That's just another way of combining referencing the overall Gleason score, with a grade group of 1 through 5 correlating to a Gleason 6, 7, 7, 8, and 9 and 10 cancer. So just different ways of combining it. But the important thing is Gleason score. There's 2 numbers. The first number that comes first is the most common pattern that is found. Okay, so let's go back to the risk classification. Again, big picture. Risk classification is determined upon 3 main factors: T stage, PSA, and the Gleason score. There's a low, middle, and high risk, and there are subclassifications within each of those. There's a very low risk group, which is essentially low volume disease, limited cores, limited disease on each core. In terms of the middle risk, there's a lower middle risk, or a favorable intermediate risk, and an unfavorable intermediate risk, or a higher middle risk, where the lower middle risk kind of looks more like low risk. A higher middle risk kind of looks a little bit more like high risk. And there's subtleties in those based upon the Gleason score, how many middle risk factors there are. And lastly, there's a high-risk group as well, with very high-risk subclassification. So as we can see, the prostate cancer-specific survival, and this is survival this is essentially a reflection of mortality due to prostate cancer. It's dependent, not surprisingly, upon which risk group it is. With on the top, with the blue being low-risk patients having the highest survival, and on the bottom, high-risk patients in the green having the worst survival. So what do we do in terms of treatment? So this is a busy slide, so we're going to go through this one at a time. So it's all based upon life expectancy. And what are we thinking about in terms of life expectancy? If the life expectancy is less than 10 years, so for example, a patient who may have had significant heart failure due to a prior heart attack, multiple strokes, multiple stents in place, on dialysis, where if the life expectancy we're not really expecting to be greater than 10 years, the best treatment is actually observation or watchful waiting. And we'll get to this a little bit later. Higher life expectancy, above 10 years, let's say between 10 to 20 years, with very low risk cancers, we recommend active surveillance. And for others in low and very low risk with very long life expectancy, completely healthy, no medical conditions, active surveillance or definitive therapy. And we've alluded to some aspects of definitive therapy previously. Surgery, as Dr. Sun has said, or variants of radiation, such as external beam radiation, internal radiation, otherwise known as brachytherapy. So there were a couple of technical terms, so I want to make sure we sort of understand the concepts and the differences. So we talked about watchful waiting and observation and active surveillance. They sound similar, but they're actually very different. So what's the difference between watchful waiting and active surveillance? Watchful waiting there's no plan for definitive therapy. We're not thinking about curative surgery. We're not thinking about radiation, but we're waiting to see, should symptoms develop, we can prescribe palliative treatments such as androgen deprivation therapy or hormone treatment to palliate symptoms. Active surveillance is an active process of serially monitoring the PSA with plans to initiate definitive therapy, surgery, radiation, if the disease progresses. And so who are the ideal populations for that watchful waiting active surveillance? Watchful waiting are patients who are unlikely to benefit from definitive therapy due to age or comorbidity. Again, that patient who's had that heart failure, multiple strokes. The prostate cancer probably wouldn't be the thing that takes them. And so sometimes less is more. We don't want to put them through unnecessary procedures. Whereas active surveillance are patients who wish to defer therapy and importantly, the associated side effects of those therapy because they have low risk disease, which may never become clinically significant. So what is the surveillance strategy for active surveillance? We would recommend that you check in with your doctor to get a PSA twice a year, and a digital rectal exam and a biopsy no more frequent than every year. So say you continue on the active surveillance protocol. What are indications? What are things that would kick sort of therapy into gear? What are indications for initiating definitive therapy? And it's essentially, the short answer is disease progression. Changes in the PSA, especially if something called the doubling time, the PSA kinetics start rising really quickly. different findings on exam. For example, 2 years ago, when your doctor did a digital rectal exam, there was no nodules found, and now suddenly there's maybe suspicion for disease that's extending outside of the capsule, or repeat biopsy. Previously, the Gleason 3+3 cancer now is showing the 4+4. Those are indications for initiating therapy. And lastly, but very importantly, also patient preference. It is very reasonable, and we have many patients who just want to get this taken care of, and that is also a big factor. So I'll conclude with just some evidence in terms of active surveillance and talk about some literature and evidence bases that we have, which is specifically the UK PROTECT trial. It's a large randomized controlled trial that was out of the UK and enrolled about 1,600 men. Median age was about 62. In the UK, they were 99% Caucasian. And in this population, most but not all were low risk. However, 77% of them were Gleason 3+3 cancers. And a third of these men went to active surveillance, a third went to surgery, and a third went to radiation. And this trial tried to answer the question of what happened to them. And as you can see from this graph in the middle here, prostate cancer specific survival, excellent, almost 100%, or essentially 99% for everybody, meaning that mortality due to prostate cancer is unchanged. The active surveillance arm did have a relative risk, high relative risk of developing sort of clinical progression or developing distant metastases, meaning spread of prostate cancer. But overall, the absolute risk is very, very low. And if you look on the graph on the right there with the colors, blue, red, and green, with the active monitoring group, you can see that 50% of patients who are on active surveillance receive definitive treatment because their biopsy showed upstaging of tumor, their PSA started going up by 10 years. So what I tell my patients is that if you choose to undergo active surveillance, the data show that at 10 years, you have a 50% chance of requiring treatment. But also conversely, if you choose to undergo active surveillance, at 10 years, you have a 50% chance of avoiding treatment and its associated side effects. The only caveat I would say would be that there's caution in generalizing to sort of patients who don't look like the patients who are on study. Again, much younger patients or African-American populations, as this was 99% Caucasian. So that's it for me. Thank you so much for your attention. I hope this was helpful, and I'm happy to take questions.
Great. Thank you so much, Dr. Qian. We are getting some questions online, and please, if you have any questions from the tables, we'll grab your cards. Got quite a few for you here. So to start with, what are the factors that determine going from active surveillance to treatment?
Yeah, so a couple. In my mind, the most important one is what the patient thinks. Patient preference is if somebody if you know that you have prostate cancer and you are not comfortable watching it and you just want to get this taken care of, that is a completely valid reason to go to treatment. However, in other cases, as we continue active surveillance, if on your repeat biopsy there shows to be higher, there's evidence of disease progression, whether that's a Gleason score that goes from 3+3 to 4+3, whether that's before only 3 cores involved, now there's 12 cores involved. Those are factors as well. The PSA is behaving like it's climbing on up. Those can be factors.
Speaking of prostate or Gleason 3+4, can you explain the difference between 3+4 and 4+3?
Correct. Yes. So that is an excellent question. This is something that's an excellent question. So the Gleason score again is the first number is the number that is the most prevalent pattern seen by the pathologist, and the second number is the second most prevalent pattern. So Gleason 4+3 cancer means that the most common pattern is a Gleason 4. Whereas the Gleason 3+4 cancer means that the most common pattern is a Gleason 3. And why does that matter? We talked about the different risk groups. There's the middle risk group, the intermediate risk group cancer. And within that subclassification, there's a lower middle and a higher middle, with the lower middle looking more like low middle risk prostate cancer, the higher middle looking like the higher middle risk prostate cancer. A Gleason 4+3 cancer is a higher middle risk or an unfavorable intermediate risk prostate cancer. In these types of patients, we at Stanford, we tend to be more aggressive in up escalating the treatment, because we think of it as getting close to a higher risk. Whereas a Gleason 3+4 cancer, if their PSA is under 10, if you don't feel anything else abnormal on the digital rectal exam, we treat it as a lower middle risk prostate cancer.
Thank you. What is the role of biomarker testing, such as Decipher, in treatment decisions? And does it indicate for more aggressive treatment if you have biochemical recurrence?
So this is I think that's actually two questions. So let's break that down. So let's just talk about biomarker or genomic studies, Decipher test. The Decipher test is a genome assay that basically looks at how aggressive the genomes, the genetic material of the cancer looks like. And basically, the way we tend to use genome tests here are, we use the traditional risk stratification scheme that we had talked about based upon those three main factors. And then for patients who, for example, a young patient who's otherwise healthy, who wants to be on active surveillance for a long time, I would get the Decipher to verify that the genomics look okay, and that it makes me a little bit more reassured that we do active surveillance. The question also asked about biochemical recurrence. Biochemical recurrence is really more of a question in regards to recurrence. What that means is a recurrence of PSA after treatment. And in that setting, I suspect the question is more referring to after surgery. So after surgery, with a prostate that's out, the PSA should be 0. In a perfect world. Sometimes the PSA comes back up, and that's called a biochemical recurrence. It becomes detectable. And in those cases, there may need to be more treatment later on. This is getting into some details. But the Decipher test can also be useful in those cases. Yeah, that's getting into a little bit of more of the details, but yeah.
Thank you. For screening PSA test, a couple things. Number one, do you need to fast? And number two, do you need to avoid sexual intercourse? Do you need to avoid bike riding? Because we know PSA can kind of fluctuate.
Yeah. Again, so there can be several factors that can cause a falsely elevated PSA. So I think a good rule of thumb is no bike riding, horseback riding. You don't need to fast for probably about at least 3 days prior.
Okay, thank you. And if I'm put on active surveillance, I have fear that the cancer is gonna spread. Can you speak to that a little bit more?
Yeah. So the point of active surveillance is that the active surveillance is a serial monitoring protocol where we are watching things very, very carefully with the goal and intent of saving you the side effects of therapy. Whether that's erectile dysfunction, whether that's urinary leakage, for as long as possible until you need the treatment. And so by watching you very carefully, you will be getting, PSAs twice a year, regular checks with MRIs, repeat biopsies to make sure your cancer has progressed. So again, this is different than watchful. This is different than watchful waiting or observation. So we are monitoring this very closely. The chances of it progressing while all of those other factors we're looking at, Gleason Score, Gleason Score on biopsy, PSA, if they're otherwise being stable, it's very rare of going to other places.
And we've heard that sugar can feed cancer. And so should we avoid sugar? And what other foods should we avoid? And what should we eat in our diets?
So I'm not the best person to be answering this question because I love sugar. And there's various, so the data on risk factors for prostate cancer on diet is limited. There's some limited evidence showing that excess consumption of high fat content, such as red meats, which I love as well, and dairy, can contribute to an increased risk of prostate cancer. This evidence basis is limited. Not so much, I'm not aware of much on sugar. There's some limited evidence that carotenoids, which are found in processed tomatoes, can potentially decrease the risks of prostate cancer. Again, the strength of this evidence is limited. But in general, I would advocate for a healthy lifestyle, as Dr. Sun had alluded to, healthy heart, healthy prostate, healthy body, 30 minutes of exercise a day, and then sort of lots of fruits, lots of vegetables. Can't go wrong.
If I'm a low-risk Gleason or low-risk candidate for or low-risk prostate cancer, but yet the Decipher shows that I'm high risk, would you still recommend active surveillance?
So it depends on several factors. We would have it. That's probably a 45 minutes discussion in clinic, where we would go through essentially nuances of your pathology report, your wants and wishes, and then go through your Decipher test. Yep.
Can PSA determine whether the PSA increase is due to cancer versus non-cancer cells? Sorry, PSMA. Can PSMA?
PSMA. So PSMA, which Dr. Igaru has talked about, is specific for prostate specific membrane antigen. So it is targeted towards prostate tissue. But in terms of the way we look at it, the reason that PSMA PET, the way we use it in clinical practice to help us determine whether or not there's cancerous tissue is if there's an abnormal lymph node somewhere in the pelvis that's lighting up, that's probably cancer. But there can be background uptake of several tissues such as liver, salivary glands, or parotid glands, submandibular glands. Those will light up too. So those are not cancer. So by itself, I would say I would rely on the interpretation from the radiologist.
Okay, and final question before our break, and this is actually for radiation therapy. Is there any evidence or trials looking at radiation therapy to lung metastases for oligometastatic prostate cancer with a rising PSA on hormone/systemic therapy?
Yeah, so my esteemed colleague, you'll be getting an upgrade after this, Dr. Bagshaw, will be talking a lot more about prostate, about radiation therapy for prostate cancer. But I can take a first crack at it, which is, so this is an emerging role in that recently, the term oligometastatic disease in prostate cancer has come up. And what does that mean? That means oligo means a few. Means prostate cancer that has spread outside of the body with just sort of 1, 2, 3, a few lesions that have spread outside of sort of the pelvis. So let's take the example of lung metastases. If there's only a couple, 1 or 2 metastases, our approach at Stanford is to be aggressive and treat those definitively or with curative intent. With high doses of radiation to try to cure you and knock back those cancers. And that is supported by evidence in the literature out of multiple institutions suggesting that aggressive treatment to oligo or a few metastatic sites of disease can indeed be associated with improved outcomes. So we are in favor of this at Stanford.
Great. I appreciate all your questions and answering the questions, and a wonderful talk. Thank you so much, Dr. Chen. At this point, we are going to do a coffee and bio break. We will reconvene at 10:45 a.m., followed by 2 more sessions, and then we're going to have a lunch break. And the 2 sessions, one of them will include 3 patient perspectives. Thank you so much.